Emphysema and chronic bronchitis by emedicine.medscape.com. Emphysema and chronic bronchitis are airflow-limited states contained within the disease state known as chronic obstructive pulmonary disease, accompanied by the destruction of alveolar walls and without obvious fibrosis. Clinically, the term emphysema is used interchangeably with chronic obstructive pulmonary disease, or COPD. This entity seeks to describe patients who have severe COPD and/or severe asthma who find themselves with frequent exacerbations, hospitalizations, and difficult-to-control or refractory symptoms. And environmental exposures, including biomass fuel cooking, also are included on the list. Women in developing countries who are exposed to biomass cooking of liquids and fuels, including wood. The investigators concluded that the need to continue to improve air quality guidelines is more important than ever, as biomass cooking in low-income nations was clearly associated with COPD mortality. Genetic risk factors for the development of COPD are also thought to exist. The most well-studied is alpha-1 antitrypsin (AAT) deficiency, also known as alpha-1 antiprotease deficiency. Have serum levels well below the reference range levels at about 20% of the normal level, 2.5 to 7 mmol/L. The normal allele phenotype is PIM, with levels of 20 to 48 mmol/L. The American Thoracic Society, European Respiratory Society (ATS), ERS guidelines recommend screening for AAT deficiency if emphysema is suspected in any patient younger than 45 years and with any of the most common type of severe AAT phenotype. More than 90% occurs in individuals who are homozygous for the Z allele. Homozygous individuals PiZZ, usually of Northern European descent, or paniculitis positive C. ANCA, anti-neutrophilic cytoplasmic antibody, vasculitis unclear, idiopathic bronchiectasis, asthma with persistent, fixed airways obstruction despite therapy. Risk factors. The risk factors thought to be responsible for the development of COPD are all associated with an accelerated decline in FEV1 over time. Leading this list is cigarette smoking. 15 to 20% of 1-pack per day smokers and 25% of 2-pack per day smokers develop COPD. Next are cigars and pipe smoke, followed by second-hand and third-hand smoke. Occupational, inhalational, crops, animal dung, and coal are at increased risk of developing COPD. Add to that poor ventilation of the home and dependent family members, children and elderly persons, risk also increases. The main purpose of this 394 amino acid single-chain protein is to neutralize neutrophil elastase in the lung interstitium and to protect the lung parenchyma from elastolytic breakdown. Severe AAT deficiency predisposes to unopposed elastolysis with the clinical sequelae of an early onset of pan-acinar emphysema. Deficiency of AAT is inherited as an autosomal codominant condition. Throughout the world, COPD is a disease of occupation and environmental pollutants too, including but not limited to organic and inorganic dusts, isocyanates, and phosphogenes. Absence of recognized emphysema risk factors such as smoking or occupational inhalational exposure, unexplained liver disease, family history of AAT deficiency, COPD, bronchiectasis, alveolar ducts, and alveolar sacs. The process is localized around the septae of the lungs or pleura. Although airflow is frequently preserved, the apical bully may lead to spontaneous pneumothorax. Loss of individual alveoli with septal wall destruction leads to airflow limitation via two mechanisms. First, loss of alveolar wall results in a decrease in elastic recoil. Focal pan-acinar emphysema at the lung bases may accompany centriacinar emphysema. Paraseptal emphysema, also known as distal acinar emphysema, preferentially involves the distal airway structures. Centriacinar, centrilobular, penacinar, panlobular, paraseptal. Centriacinar emphysema is the most common type of pulmonary emphysema, mainly localized to the proximal respiratory bronchioles with focal. Once innate respiratory defenses of the lungs' epithelial cell barrier and mucociliary transport systems are infiltrated by foreign, invading antigens, noxious cigarette ingredients, for instances. It is here where the release of neutrophilic chemotherapeutic factors is thought to occur. Proteolytic enzymes like matrix metalloproteinases (MMPs) are mainly released by macrophages, which lead to destruction of the lungs' epithelial barrier. Macrophages are found to be 5 to 10-fold higher in the bronchoalveolar lavage fluid of Emphysema potens. Also, this is why neutrophils are thought to be very pathogenic in emphysema at the tissue level, a differentiator to the mainly eosinophilic inflammatory response in airways affected by asthma. After all, proteases are produced by inflammation, macrophages, and epithelial cells, which fuel bronchiolar edema from an elastin-destroying protease-antiprotease imbalance. This protease menaces elastase, released by macrophages, and responsible for the breakdown of the lung's fragile elastic lamina, of which elastin is a structural protein component. This is central to the development of emphysema, which is expressed in airway smooth muscle cells and responsible for increased risk in abnormal patterns of fibroblastic development. It is these structural changes of mucus hyperplasia,